in for today's meeting. Thank you for joining in today's CAD-A-THON meeting. This is a series of meeting on ECG Masterclass, and this is a second in that series. And there are many more interesting topics which are going to come under the CAD-A-THON banner. This is a joint meeting by ISE and Merck, and we welcome you all for today's meeting. Today's meeting is going to focus on arrhythmias basically, and how beta blockers also play important role in a heart rate control in all that aspects. So without much ado, I just wish to introduce our today's esteemed faculty. We have Dr. Dayanand Kumbla sir, who is a moderator for today's meeting. He's associated with many hospitals. We have Dr. Dayanand Kumbla sir since its inception, the founder of Jayanand Hospital, Charai, Thane, and he's practicing in Thane since 1986. Sir has decades of experience and will be moderating today's session. We have Dr. Ashish Nasser, who is a electrophysiologist and is again certified from Netherlands. He is also associated with multiple hospitals in Mumbai, and he's a visiting consultant at KEM hospital at the same time. He is a member of multiple societies. He's the first in the country to be awarded as a PhD in the cardiac electrophysiology and has done multiple publications, awards, and recognition. So welcome, Dr. Ashish Nabar, sir. And we have Professor Dr. Mohan sir, who is a chairman HOD of the Department of Cardiology at Jaipur Golden Hospital. He has been the ex-president of IE, ex-professor at GB Pant, past director of Fortis, and president at Apex Society, CME, and Sujay B. Roy Gold Medalist also, and so president at Apex Society. Welcome, sir, for today's meeting. Sir will be talking on beta blockers and the perspective in tachyarrhythmias. This is the agenda which Dr. Kumbla sir will be taking ahead. But for our audience, just one request that there will be polling which will come in between. We will intimate you the video of, if you are watching it on a on mobile, then please video should not be in the full screen mode, otherwise you will not be able to see the question. You have to just rotate it vertically so that you can see the all the options and you can just click any one of them. Your poll is submitted. So with that, I just hand over session back to Dr. Kumbla sir for his opening remarks. Over to you, sir.
At the outset, CAD-A-THON for inviting me for this session as a moderator. Thanks, Dr. Chaudhary, for giving me a great introduction. Today's lecture, we will have two speakers. First will be Dr. J.C. Mohan. As you already know, he is a senior consultant in Delhi. And second will be Dr. Ashish Nabar, famous electrophysiologist at Mumbai, visiting various hospitals, is already introduced. First lecture by Dr. J.C. Mohan will be on beta blockers and to control the rate. In the process of controlling rate, is the use of beta blockers. You know, beta blockers to control the rate can be used in atrial stutter, atrial fibrillation, many a times even in patients with heart failure with reduced ejection fraction, and then use beta blockers to control the rate, control the failure part. Next lecture by Dr. Ashish Nabar will be on ventricular arrhythmias. You know, ventricular arrhythmias basically come from the lower part of the ventricle. So atrium and the AV nodes, atrium is not involved, so you get ventricular premature complexes with a broad QRS, and at the same time, sir may also talk about ventricular tachycardia, short QRS. Now going back to Dr. J.C. Mohan, invite you to start your lecture.
Thank you, Dr. Kumbla, for the introduction and introduction to the subject. And I have been given the mandate to talk about beta blockers and rate control. I would also be focusing for a few minutes at the end of my presentation on bisoprolol as a unique molecule. I have no conflict of interest with regard to this presentation. Sympathetic nervous system maintains homeostasis of body. It is largely protective, and it sometimes becomes toxic. The sympathetic nervous system works through end organ receptors, which are of two types, alpha receptors and beta receptors. Alpha receptors are again of two types, alpha 1 and alpha 2 receptors, and beta receptors are of three types, beta 1 receptors, beta 2 receptors, and beta 3 receptors. Our focus today is going to be on beta blocking drugs, and hence we would be discussing beta receptors. As the beta receptor agonists like epinephrine, norepinephrine, and dopamine are released at the postsynaptic nerve endings, these occupy what we call as beta adrenergic receptors on specific tissues like myocardium, like juxtaglomerular apparatus in the kidneys. And they initiate a cascade of intracellular messages and intercellular processes. In myocardium, 80% of the beta adrenergic receptors are beta 1, 20% are beta 2, largely in atria, and currently is also being discussed that probably there are a little bit of beta 3 receptors as well. These beta receptor agonists, which are circulating as catecholamines, basically work on this transmembrane beta adrenergic receptor, which is a heterodimeric G-coupled receptor protein. And through this, it increases the cyclic AMP, which is the second order messenger in the cytosol. Cyclic AMP leads to phosphorylation of protein kinase A, through which it becomes active. And active protein kinase A performs certain functions. We need to understand that beta receptor is an adrenergic heterodimeric G protein coupled receptor. That is the first thing we need to understand. And second is G protein coupled receptors are transmembrane proteins that act as gatekeepers between external signals and cellular processes. Once you have activated protein kinase A, this will activate ryanodine 2 receptors, sodium calcium channels by phosphorylation. There are multiple enzymes which undergo phosphorylation. Voltage dependent calcium channels undergo phosphorylation. The end result is increased inotropy, increased chronotropy, increased lucitropy, and increased dromotropy. So in short, catecholamines increase cyclic AMP in the cytosol, which activates phosphokinase A, and phosphokinase A phosphorylates multiple enzymes and channels, end result of which is, as I said, increased inotropy, increased chronotropy, increased dromotropy, and increased lucitropy. The process gets reversed by an enzyme called phosphatase, and this cycle goes on in the myocardial cells. Beta adrenergic receptor blockers, which block these receptors and hence do not allow the ligands like epinephrine, norepinephrine, or dopamine to work on these receptors, have been shown to have a multitude of actions like neutralizing cardiotoxicity of catecholamines, anti-ischemic action, anti-hypertensive action, blocking renin release from juxtaglomerular apparatus, anti-arrhythmic action, of which we are interested and will be talking about it in detail, improving myocardial energetics, inhibition of apoptosis, reducing shear stress on plaques, antioxidant properties of beta blockers, anti-inflammatory properties, upregulation of beta receptors, especially in heart failure, antiplatelet action, which is usually mild and weak, and of course, myocardial gene expression. Those are some of the things through which the beta adrenergic receptors work in human body. Beta blockers actually can be divided into three categories. First generation, which were non-selective, typical example being nadolol and propranolol. second generation selective, classic example being bisoprolol, metoprolol, and atenolol, and third generation, which are vasodilatory beta blockers, examples being nebivolol and carvedilol. Beta blockers, in addition, actually also have, some of them have partial agonism, that is called intrinsic sympathomimetic activity, like oxprenolol and S-butalol, and some have inverse agonism, like propranolol. By and large, they are neutral antagonists of beta-adrenergic receptor agonists. So these can be selective or non-selective. Few of the beta blockers which we commonly use in clinical practice are here: metoprolol, bisoprolol, esmolol, propranolol, and carvedilol. We would be discussing these as a group or as a class rather than discussing these separately. However, as I said, I would be spending about 5 minutes on bisoprolol at the end of this presentation. So now, since the topic is rate and rhythm control with beta blockers, we need to understand that rate and rhythm disturbances are common in human body. Those can be as a result of physiological stressors like exercise, which not only can produce sinus tachycardia, but sometimes ectopic activity. You can also have electrophysiologic stressors like ischemia or abnormal channels, and you can have pathological stressors like microscars, which all can lead to rate and rhythm disturbances in human body. The conduction system of the human heart is where the beta-adrenergic receptors are going to work. These do work at the level of sinoatrial node, AV node, bundle of His, and Purkinje fibers. However, in atrial musculature, beta-1 adrenoceptors are not present. On the other hand, beta-2 adrenoceptors are present. End result of catecholamine stimulation is increased rate of depolarization, and hence you see faster conduction through the SA node and AV node, shorter effective refractive period, and shorter action potential duration. Those are the electrophysiological effect of sympathetic stimulation. So what kind of arrhythmias do we see in India? The typical profile of cardiac arrhythmias and heart failure patient in India is 58% of all those patients who show arrhythmia actually have heart failure. Bradyarrhythmia is present in 15% of all patients who are seen in OPD. Atrial fibrillation 15%, supraventricular arrhythmias, other supraventricular arrhythmias 10%, ventricular tachycardia, oblique fibrillation in about 4.5% patients. How does arrhythmogenesis occur? You need to have three conditions fulfilled before one can look at arrhythmia or what can see the genesis of arrhythmias. There is a signal production, there is signal propagation through the tissue, either specialized tissue or through the myocardium, and then there can be differential pathways, signal pathways, and if there are differential pathways with different physiological, electrophysiological properties, these promote re-entry, and hence one sees arrhythmias. Those are the basic reasons why, because beta blockers are capable of suppressing the signal production, that is extrasystolic signal propagation, by prolonging the conduction time and prolonging the effective refractive period, and of course blocking one of the limbs of the reentrant pathway. So the signal pathway is also altered by beta blockers. What type of arrhythmias are common? The arrhythmias are supraventricular or ventricular. Supraventricular can be purely atrial, like atrial fibrillation, AV nodal reentrant tachycardia, accessory pathway like AV reentrant tachycardia. These can be ventricular, which can be monomorphic, or which can be sustained or non-sustained, monomorphic VT, polymorphic VT, ventricular fibrillation, ventricular ectopics, and of course again the ventricular tachycardia can be automatic, triggered automaticity re-entry. In general, whenever there are tachyarrhythmias, they increase the risk of death. Atrial arrhythmias increase the risk of death by about 30%. Ventricular arrhythmias increase from 200% to 2000%. We just have to keep in mind that the supraventricular or ventricular arrhythmias are almost never benign. What is the aim in a patient who has got tachyarrhythmias? We want to do immediate stabilization. Sometimes patient may need electric cardioversion. Rate control, where the beta blockers come in picture, and also, of course, non-dihydroproteinase calcium channel blockers. Rhythm control, where, of course, anti-arrhythmic drugs play a big role, but to some extent, beta blockers also provide rhythm control, although they are weaker as far as rhythm control is concerned. Except in certain situations in ventricular arrhythmias where they provide a good rhythm control. Preventing complications is another important aspect of treating tachyarrhythmias, and that is if these individuals are susceptible to thrombus formation like atrial flutter fibrillation, anticoagulation may be required. Preventing future episodes, where multiple ways of doing it, catheter ablation, pacemakers, or ICD. Treating underlying cause is the single most important thing when you encounter a patient with tachyarrhythmia, and those causes could be thyroid disorders, electrolyte imbalance, hypertension, or structural heart disease. Okay, here is actually a whole algorithm for treating tachyarrhythmia and heart failure. I would try not to read this, but I will go with you on a much simpler way of management. But let's remember one thing, that even in today's era, beta blockers maintain their position as an important component of therapeutic armamentarium. Beta blockers can intervene at many points in cardiovascular continuum, but we also have to remember one thing, that the halo around beta blockers is getting little fainter now that last 2 years we have got studies like reduced AMI and reboot trials, which have shown that post-MI preserved ejection fraction patients do not get any benefit from beta blockers. Also, few weeks back in ACC, a good French trial showed that discontinuing beta blockers in post-MI patients who have ejection fraction above 45% actually produces no discomfort to patients or no long-term ill effects. This is just to tell you that science is progressing, new things are coming up, and we have to keep our strategy in line with the new evidence. So first thing first, how do beta blockers impact ventricular arrhythmia? The commonest way is by ischemia amelioration. Ischemia begets arrhythmia. Ischemia actually leads to delayed sodium current activation that increases the cytosolic calcium, which increases the diastolic tension and increases oxygen consumption, and hence the cycle goes on. This is how the sodium in cell and calcium overload in cell both actually produce ventricular arrhythmias. So the ischemia leads to augmentation or opening of late voltage gated sodium channels, and that is the commonest mechanism by which ventricular arrhythmias are generated. This is a cartoon to show the same thing. On left side is a normal action potential, and on right side is because of ischemia, there is a prolongation of the action potential because of the late sodium current entry. That leads to after depolarizations, which produce triggered automaticity, hence arrhythmias. We also understand that whenever the cytosolic calcium is more, as in ischemia, this would actually lead to more phosphorylation of sodium calcium exchanger and sodium potassium exchanger, resulting in sodium poisoning of the cells and hence provide an electrophysiological substrate for arrhythmias. Beta blockers are indicated in a variety of supraventricular and ventricular conditions, and we would talk about these as we go forward. So we know that there are situations in human cardiovascular diseases where there is a hyperadrenergic state. Hyperadrenergic state works both as a trigger and substrate for arrhythmias. Trigger is increased automaticity, triggered automaticity, and extrasystole, and substrate is shortened action potential duration and heterogeneity in repolarization. Ventricular arrhythmias are usually associated with myocardial ischemia, long QT syndrome, especially type 1 and 2, catecholamine-mediated ventricular tachycardia, and herein sympathetic nervous system is pro-arrhythmic and parasympathetic nervous system is anti-arrhythmic. However, there are situations where reverse of this may happen. For example, LQTS3 or LQS type 3 reverse happens where sympathetic nervous system actually is to some extent anti-arrhythmic and the reverse is also correct. Let me show you how actually the beta blockers work in individuals, certain individuals who have relatively normal function but have ventricular arrhythmias. These individuals have what is called increased mechanical dispersion. Shown here, you would read this slide, it shows you PSD of 82.8 millisecond. This patient has normal ejection fraction, normal global longitudinal strain, but what you are carefully seeing is that the strain dispersion is more. The mechanical dispersion is increased because the standard deviation is 83 millisecond against a normal about 35, 40 millisecond, indicating that there is mechanical dispersion which is increased, and this actually classifies these arrhythmic potential is these patients superior to ejection fraction, as in this particular individual who has critical left anterior descending artery stenosis. We know that beta blockers reduce the dispersion of mechanical dispersion of the myocardium, and that is how these work. Beta blockers work in certain types of long QT syndrome, post-MI situation, laminopathies, mitral valve syndrome, and also catecholamine-mediated ventricular tachycardia. So where do exactly beta blockers work? Classically, beta blockers have a role in atrial fibrillation, largely for rate control, but also to some extent for prevention of atrial fibrillation and those people who are predisposed to atrial fibrillation. Beta blockers also are helpful in treatment of ventricular arrhythmias, which are related to increased sympathetic activity associated with myocardial infarction, heart failure, physiological or pathological stress. Ventricular arrhythmias are also, the beta blockers are also affecting certain other ventricular arrhythmias, like, as I said, catecholamine-mediated ventricular tachycardia, certain types of long QT syndrome, laminopathies, and certain other type of genetic cardiomyopathies, which are essentially channelopathies. So let us talk about beta blockers in atrial fibrillation. According to guidelines, use of beta blockers for control of rate is a class 1 indication. And those who do not respond adequately to beta blockers should be combined with digoxin, especially in those individuals who have ejection fraction less than 40%. Those are class 1 indications. And this data has come out largely from a couple of randomized trials, the most prominent of which is a AFFIRM trial, although it is nearly a 25 years old story, but AFFIRM trial showed that in patients with atrial fibrillation, the rate control success was best with beta blockers, either alone or with digoxin. 70% patient had a desired rate control, what we call rate in therapeutic range. Digoxin was number 2 drug to control the rate 58% of individuals, and calcium channel blockers, either alone or along with digoxin, were effective in controlling the ventricular rate in 54% cases, clearly showing that beta blockers are the preferred drugs for rate control in patients with atrial fibrillation. The other interesting aspect actually is that post-CABG patients or post-operative patients have a predisposition to develop atrial fibrillation nearly in 15 to 40% of these individuals. And it has been suggested that beta blockers should be initiated right from day one after bypass surgery, because beta blockers will prevent occurrence of atrial fibrillation and also would control the rate in case atrial fibrillation occurs. And for this reason, the ACCHA 2021 guidelines have given a class 1 status to beta blockers as soon as possible after bypass surgery to reduce the incidence or clinical sequelae of post-operative atrial fibrillation. That data also has largely come from another study, and this is also incidentally called the AFFIRM study, where it was shown that at the end of 60 days post-CABG, whether you gave amiodarone for rhythm control in patients who develop atrial fibrillation, or you gave drugs like bisoprolol, at the end of 60 days, there was no difference with regard to people who are free of atrial fibrillation. Nearly 85% individuals were free of atrial fibrillation at the end of 2 months, whether you controlled the rate with beta blockers or you gave amiodarone. However, the first 7 days did show that amiodarone was superior to beta blockers. Based upon this trial, beta blockers have been given a status equal to amiodarone in post-CAG patients for prevention of atrial fibrillation and controlling it sequelae. If we look at the same study which I just discussed, the mean hospital stay was similar whether you use rhythm control with amiodarone or rate control. Hospital days during index hospital were the same, and remote hospitalization also, the days in the hospital were same, indicating that beta blockers rate control is as good as rhythm control by amiodarone in post-CABG patients. We also know that beta blockers are used in heart failure patients. These work better in individuals or heart failure with reduced ejection fraction who are in sinus rhythm, as shown in the graph on the left side. But they do work in patients who have atrial fibrillation, although that effects gets significantly attenuated. Once patient has atrial fibrillation, the all-cause mortality does not get so much affected positively once patient has atrial fibrillation. And this point we need to keep in mind. Although beta blockers are the preferred agents to control rate in atrial fibrillation in heart failure with reduced ejection fraction, rate control in sinus rhythm with beta blockers is far more dividend paying than in individuals who have atrial fibrillation. Before we understand ventricular arrhythmias and the role of beta blockers, we need to understand the cardiac action potential. The action potential, 4 phases. Phase 0, which is depolarization phase because of the sodium entry, channel entry, sodium entry. Then there is a phase 1, where there is early potassium outflow. Phase 2, which is as a result of actually the balance occurring, and phase 3 again is a outflow potassium rectifier current, delayed potassium rectifier current, and phase 4 basically is a hyperpolarization activated cyclic nucleotide gated channels, which produce what you call as where one does see after depolarization potentials in certain situations. Beta blockers largely work as class 2 antiarrhythmic drugs, mostly on phase 2, but they also work on phase 1 and phase 4 too. So this is how beta blockers work. Actually, the beta blockers, as a class 2 effect, they will slow the conduction. They will slow the atrioventricular conduction, hence reduce automaticity. Some of the beta blockers have membrane stabilizing effect, that is, they have class 1 property, by virtue of which these actually tend to decrease the early after depolarization and delayed after depolarization. Beta blockers also have some class 3 properties by virtue, especially drugs like sotalol, which increase the duration of action potential, increase the effective refractive period, and also the duration of repolarization. So here is the old William Vaughan classification of anti-arrhythmic drugs. Largely, beta blockers are still considered class 2 agents, but as I said, they do have some class 1 properties and some class 4 properties, especially carvedilol has some class 4 calcium channel blocking properties. And by virtue of these drugs work as powerful anti-arrhythmic drugs in ventricular arrhythmias. Capricorn study post-MI patients with reduced ejection fraction in those subset of individuals who had a Holter monitoring did show a reduction in atrial fibrillation nearly 57% in those individuals who were given carvedilol compared to standard of care and placebo. And VT and VF documented on Holter were reduced by 76%. That impressive number actually resulted also in reduction of sudden cardiac death in these individuals. We saw the similar kind of results in CBS2 trial with bisoprolol, wherein bisoprolol was shown to cause 44% reduction in sudden cardiac death. And as we know that 3/4 of the sudden cardiac death is tachyarrhythmic in origin, we would believe that beta blockers have positive impact on tachyarrhythmia, hence on sudden cardiac death. Beta blockers are also useful in individuals who have long QT interval, and these are known to reduce long QT, the QT interval, more so those who have heart rate above 100. There, the QT interval is reduced by nearly 10 to 14 milliseconds, and that helps in stabilizing actually the membrane of these individuals. Beta blockers are effective in type 1 and type 2 long QT syndrome, because here adrenergic triggers actually precipitate ventricular arrhythmias, but they may be potentially harmful in long QT syndrome type 3 because these here arrhythmias occur mostly during rest or during sleep. Catecholamine-mediated polymorphic VT is another genetic disorder wherein beta blockers are extremely effective. And it has been suggested that those individuals who present with sudden cardiac arrest or arrhythmic syncope, beta blockers are class 1 indication. They are also class 1 indication who manifest with polymorphic or bidirectional VT. They are class 2 indications on those individuals with this catecholamine-mediated ventricular tachycardia who are genotype positive but phenotype negative. Beta blockers do reduce the incidence of shock after ICD implantation, and the data has suggested that these are they work in tandem with amiodarone, and hence if you give beta blocker alone or combination amiodarone plus beta blocker, you see a 73% reduction in appropriate shocks.
And you go home then.
Comparing sotalol with beta blocker, also sotalol is more effective than other beta blocker, non-sotalol beta blockers, because sotalol has class 3 antiarrhythmic efficacy. Cardiovascular deaths also are significantly reduced when to the standard therapy like amiodarone beta blockers are added, or to the ICD beta blockers are added, compared to ICD alone or amiodarone alone, clearly indicating that beta blockers potentiate the benefits of amiodarone and ICD. The favorable effects of beta blockers are because these reduce the ventricular repolarization heterogeneity, and also these lead to remodeling of ion channels. However, reduction in heart rate is not the only mechanism of antiarrhythmic efficacy. The data from CBS2 trial shows that the benefit of bisoprolol was regardless of reduction in heart rate. Even those individuals who showed an increase in heart rate, as shown on the extreme right corner, they had similar 35% reduction in all-cause mortality compared to same 36% reduction mortality in those who showed a decrease in heart rate of 11 or more. Clearly, reduction in heart rate is important, but it is not the dominant mechanism of benefit of beta blockers. The whole area of perioperative beta blocker use has been controversial. Some of the earlier studies were positive, the current studies have been negative. However, it is still considered by many that beta blockers may be useful in preventing postoperative atrial fibrillation and ventricular arrhythmias. Although we know that hard outcome like death, myocardial stroke are not affected by non-cardiac perioperative use of beta blockers. As I said, the last 5 minutes I'm going to use to talk about bisoprolol. Problem with beta blockers, we have infinite choices. We can use any of the beta blockers, and some actually have proven efficacy over the other. For example, nadolol works much better actually in catecholamine-mediated ventricular tachycardia compared to other beta blockers. So we have infinite choices, and choices of beta blockers should depend upon absorption of the drug, bioavailability, metabolism, lipophilicity, crossing blood-brain barrier, intrinsic symptomatic activity, and selectivity. Let us focus on bisoprolol. Bisoprolol is highly cardiac selective beta blocker. The half-life is 17 hours. It is 90% bioavailable. Renal excretion 50%. It is hydrophilic, and it's 30% protein bound, so it is a long-acting drug. It has certain advantage over many of the beta blockers. It doesn't cause erectile dysfunction. There is no effect on lipids. It has no effect on HbA1c. It is poorly dialysable, so you can use in individuals who are on dialysis. As I said, it is hydrophilic. Much more importantly, it has a linear dose response curve, and the reason is it does not undergo first pass metabolism in the liver, unlike other beta blockers. And here is the study to show that if you are really looking at the coefficient of variation with regard to the blood levels, actually, the bisoprolol has the lowest and metoprolol has the highest. Nebivolol is also shows a 10-time variation in the blood levels for the same dose compared to bisoprolol, clearly indicating that bisoprolol is a good choice actually when you want a predictable response to the beta blockers. And the reason obviously is this first pass metabolism, which most beta blockers undergo through the CYP2D6, while this bisoprolol does not undergo that metabolism through this cytochrome P enzyme. So the bisoprolol, the advantage, as I said, are longer half-life, better absorption, very little first pass effect, less than 10%, and 90% bioavailability and 30% protein binding. And so it is convenient to use once a day, and the dose response curve is relatively linear, and it can be given to people who actually have CNS side effect with other beta blockers, and also it can be given individuals who are on dialysis and doesn't cause erectile dysfunction, lipid abnormalities, or glucose-related abnormalities. So the drug has been used in number of arrhythmias, the ventricular arrhythmias, and of course, there is a whole review of this thing. But there are studies to suggest that in individuals with non-ST elevation myocardial infarction, using bisoprolol has been shown to decrease actually ventricular arrhythmias, MACE, and cardiac death. And these are some of the inspired studies. I would say that the benefit is there, but we just have to keep in mind that people who get benefit are those where the beta blocker started early on rather than late. The beta blocker like bisoprolol have been used in treating frequent premature ventricle contractions, and these reduce the premature ventricle contraction by nearly 50% over Holter monitoring. And why it is important to suppress PVC? Because PVC burden has a bidirectional relationship with heart failure and sudden cardiac death. If a drug is capable of reducing the PVC burden, hopefully it will prevent occurrence of heart failure and sudden cardiac death. And as we know, bisoprolol is capable of reducing the PVC burden by nearly 50%, as has been shown in this study, which has been highlighted here. The PVC burden also correlates with not only the left ventricle ejection fraction reduction, incident heart failure and mortality. For every doubling of the PVC burden, the heart failure occurrence actually increases by nearly 8%, and mortality increases by 6%, and hence it is necessary for PVC suppression. And even very healthy individuals who have frequent PVCs, bisoprolol is indicated. The diurnal paroxysmal atrial fibrillation is another condition in which bisoprolol has been shown to be effective in reducing the episodes of diurnal and nocturnal paroxysmal atrial fibrillation. Not only that, it improves the symptoms, improves the quality of life, and of course, more people are in sinus rhythm. In addition, bisoprolol has been shown to be effective actually in preventing ventricular arrhythmias and atrial arrhythmias post-CABG patients with reduced ejection fraction. These are some of the small studies. The whole idea is to tell that there is actually that the drugs like bisoprolol are being used. So I would actually try to say that there are data to suggest that bisoprolol is as effective as sotalol in maintaining sinus rhythm after atrial fibrillation conversion, and this is something which is interesting because sotalol has class 3 properties, while bisoprolol does not have, but somehow because of the mechanism by working on the duration of action potential, effective refractive period, and of course suppressing the delayed after depolarization, it seems to be working as good as sotalol. So to summarize, ladies and gentlemen, beta blockers remain the cornerstone for rate control in atrial fibrillation. The rate control is consistent at rest and during exertion, unlike calcium channel blockers and digoxin. It is preferred in patients coexisting coronary artery disease and heart failure with reduced ejection fraction where you can't use CCB. And of course, digoxin has a narrow therapeutic window. The effective rate control with proven mortality in HFrEF is known as it showed the sudden cardiac death is reduced by 44%, all-cause mortality reduced by 35%. In individuals with bisoprolol, in those individuals who have heart failure with reduced ejection fraction, the beta blockers are effective in sympathetic-driven tachycardia, exercise, stress, post-MI, and beta-1 selective agents improve tolerability in comorbid conditions like COPD and metabolic conditions. And in the end, bisoprolol has robust data on supraventricular tachycardia and good data on ventricular tachycardia and PVCs. Thank you very much.
Thanks, Dr. J.C. Mohan, for a wonderful, exhaustive lecture on beta blockers to kill heart failure. Now, I think we should invite Dr. Ashish Nabar for his talk on ventricular arrhythmias and ECG changes.
So you are not audible, Dr. Nabar, sir.
Am I audible now?
Now better, yes. You're audible now, sir. Sir, not audible at this moment. Yeah, I think headphones might creating the issue. Yeah.
Headphones. Am I audible now?
Now audible. Yes, yes.
याला तर पाहिजे आवाज. आता बघा. Hello, am I
Hello,
audible
sir.
now?
Yes,
Am I
sir. You're
audible?
audible. Yes, sir. You're
Okay.
audible.
Okay, fine. So I'll share the
Yeah.
screen. Is the screen seen?
Yeah, we can see, but not the full screen, sir.
No, no, that's sure.
Ah. So whenever polling question come, just let us wait
No, no,
there.
forget that. I'll do it my way.
Okay, fine.
Yeah, now you can hear me and see the screen.
Yes, perfect. All good, sir.
Okay, so let's start. Sorry for that. And I always enjoyed listening to Professor Mohan. It's always nice. Let's come to the talk on ventricular arrhythmias, where obviously we start with the PVC, a premature ventricular complex. Now, as that name suggests, and usually it will be a little earlier than the next sinus beat, it will be a wide QRS, and there are secondary STT changes which a mindful person should not confuse with an ischemia. And usually there is a full compensatory pause following the PVC because many times the retrograde VA conduction does not happen. And therefore, so when you're reading a Holter, it becomes important that you realize these features of a PVC because there you're usually reading a single lead or at the most three leads. So here is what I defined. You can see that clearly you have a PVC where the complex is premature, it's wide QRS, and there is T inversion. So it fits into all that we discussed. I'll use the pointer so that it becomes slightly easier. Okay. Now, this is one discussion when the PVCs were evaluated was whether the frequency of PVCs is something that makes a difference. Here you see that the PVCs are in bigeminy, meaning a sinus beat followed by a PVC, and this pattern, keeps repeating. So obviously the burden of PVC is going to be high. For example, if it goes on through the day, you will have a 45 to 50% PVC burden. And is that burden more important or is the frequency more important? Now, what is important in this particular ECG is to realize that these are outflow tract PVCs, tall PQRS in 2-3 AVF and LBV pattern. So if you stretch out your neck further, you can say this is an RVOT PVC. And this is typically a location of an benign PVC. If you look at the normal QRS, you can see that the QRS is normal. So most likely this patient does not have a structural heart disease, and therefore I call it as an idiopathic outflow tract PVCs, which usually are benign and not associated with sudden cardiac death. But whenever a patient comes to you, and they will come more often calling it as a bradycardia, because what you see is what they feel is this sinus beat and then another sinus beat, and they call it sinus bradycardia. You record a ECG and you surprise them when you tell them, no, it's not brady. Actually, you have an extra beat coming, because you can see it on the ECG. They can't see it on the pulse. They can't see it on the monitor. They can't see in the BP machine. And therefore, the question is now how to go ahead with this. This is very common. People these days do executive health checkups, they record ECGs, holters, they come up with these kind of PVCs, which are many a times common when they're isolated, when they're in a low number. You can usually pass them off if the heart is structurally normal. This can be a general understanding, and they often come with this slow heart rate or irregular pulse kind of a complaint if they are or they may really complain about some palpitations. So there will be different ways they can present. Question is, how do you triage them? How do you decide the seriousness? Most important is, what does the underlying QRS and sinus rhythm, and what does the echo suggest? If there is no structural heart disease, usually the PVCs do not have very serious prognostic implications. Absence of structural heart disease is the most important aspect, and then whether you should treat it will depend on whether they have symptoms. And when you do a echo, sometimes you need to realize that the frequency or the PVC load can itself lead to a reduction in LV function, where we coin in the term called PVC induced cardiomyopathy. PVC causing a VF is a relatively rare thing, and that is called as an idiopathic VF. So basically, structural heart disease is what you should go home with as a message, that if there's no structural heart disease, many times your PVCs will turn out to be benign. And then I introduced this term called PVC induced cardiomyopathy, which means that if the LV is dilated, losing its bullet shape, becoming a little spherical, there is mild reduction in LV function, the burden is high. When you do a Holter, daytime burden is more than 20%, for example, then these PVCs are responsible for the cardiomyopathy. So it is reverse of what you normally think. Yes, LV dysfunction leads to PVCs, but PVCs in a high burden can lead to LV systolic dysfunction, which we call as PVC-induced cardiomyopathy. Let's move on. So this is what is idiopathic. Idiopathic sometimes you may have to rule out a coronary artery disease, but mind you, every time you have a PVC doesn't mean you do a MRI and coronary angiography. That would be the wrong message to send home. So these are basically idiopathic PVCs, which can be detected in an asymptomatic person because it records the ECG. It can be with palpitations because they feel those PVCs as thuds or as short runs, or sometimes they may just call as breathlessness or discomfort while exercising. And the trouble sometimes in people who have devices is that these PVCs will sometimes not allow a biventricular pacing because they are too frequent. So there are different ways in which the PVCs can present. The last one is a little nuanced way. Here is the incidence of cardiomyopathy. We do not necessarily know how much of PVC burden and how much duration of that burden leads to cardiomyopathy, but the general good understanding is if the PVC burden is more than 20%, then one should wonder whether the underlying LV systolic dysfunction is in fact a PVC-induced cardiomyopathy, and suppressing this or ablating them might help to reverse the cardiomyopathy. So this is one understanding of ventricular arrhythmias, where they are coming as benign PVCs at the most may sometimes be responsible for a PVC-induced cardiomyopathy, a nuanced diagnosis which you must weigh in if you have the certain burden of PVCs happening. The diametrically opposite version is sudden cardiac death or sudden cardiac arrest. What that essentially is defined as a natural death within 1 hour of onset of symptoms, or sleep, or death in sleep. People, you did not get a chance to do anything. The death was unexpected. This is sudden cardiac arrest or sudden cardiac death. Now, why is this happening? Most of the time, sudden cardiac death or sudden cardiac arrest is because of VT or VF, as you can see here, and polymorphic VT. For example, bradycardia is hardly 15%. So most reasons of sudden cardiac death are arrhythmic. Most of the times it is ventricular arrhythmia in some form or the another. Ventricular arrhythmia is better because if you get a chance to shock, then this patient will be revived, as compared to that a brady or asystolic kind of a death is usually non-resuscitable. Here is what I mean to say. You have a PVC. In this case, it came very close on top of the T wave. Another time it came very close and that did something wrong. It set a polymorphic VT, which didn't VF. And unless there was a shock here, this patient would have been no more. So it is important that prevention of sudden cardiac death involves a lot of community participation. To understand, recognize sudden cardiac death, start a CPR, something that we are still learning or trying to increase the numbers of the innocent bystanders who can give a CPR. What is the most common cause of a sudden cardiac arrest? Obviously, many times it is clear, it has to be clearly understood that it is acute coronary syndrome. For example, if you look at the ECG here, this is a patient who has an MI ST elevation in one AVL. So even a small infarct can be responsible for ventricular fibrillation. This one is not small. This is an interval MI, large interval MI. And what it did was, and this patient was had a sudden cardiac arrest, was resuscitated, brought to the emergency. The next step when you record a ECG in a post resuscitated patient is to do an angiography. In this case, it was clearly a left ventricle descending occlusion. Stented, this patient will survive if everything happens in good time. Another thing is the left main coronary artery disease, which you can call sudden cardiac death. On the post resuscitation ECG, you can see ST depression in a lot of leads. So you can have either a ST MI, ST elevation MI, or you can have non-STEMI situation, which can cause sudden cardiac arrest due to the ventricular arrhythmia. But the primary cause is an acute coronary syndrome. It is important to recognize this on a post resuscitation ECG, because then this patient will be brought to the cath lab. Of course, one important thing is to know the neurological status before you bring these patients to the cath lab. That is the second part that I wanted to say. So first was PVCs, idiopathic many a times in structurally normal hearts. Second was the other extreme where you get into a sudden cardiac arrest situation, and the CPR or a bystander CPR is more important. Many times you get people who have a VT and they are stable VTs. It's possible that slow VTs can be stable, but not necessarily always so. For example, this patient had a VT rate of about 160, and this is sustained monomorphic VT. What this means, if the VT lasts for more than 30 seconds, if the beat to beat morphology is same, it has to be labeled as sustained monomorphic VT, has to be understood that way, because this means that there is a scar in the heart. So can you tell where the scar is? Probably not in this ECG, but if you have a QR pattern in any of the leads in sustained monomorphic VT, then QR pattern tells you more about the location of the scar. A QS pattern may not necessarily tell you that. So sustained monomorphic VT is equivalent to scar. Now it is possible that the sustained monomorphic VTs keep happening again and again. The first time you would probably terminate the VT if hemodynamic unstable with shock, if hemodynamically stable with IV amiodarone. We do not have IV procainamide with us, but that's another good drug in people who have sustained monomorphic VT. If this VT keeps recurring, so if you have more than 3 episodes or episodes which last for 12 hours or more than 3 shocks from an ICD device due to a VT or appropriate therapy as it is called, then this is called as a VT storm. Now, clustering of any ventricular tachycardia episodes, the sustained monomorphic VT episodes, is bad news. Why? Because these people have lesser and lesser survival if the VT keeps on happening, if the VT clusters. Now, this cluster may be over hours, maybe over days, maybe over weeks, maybe over months, maybe over 6 months, whatever it is. But clustering of VT episode, one should understand, is a bad news. The myocardium is not good, and therefore these VT episodes are now happening frequently. This obviously requires emergency management. Another kind of a clustering is ICD shocks. Now, ICD shocks, if they're inappropriate, if they happen in quick succession in a short time, this patient is not going to tolerate, is going to search for where his ICD implanter is, trying to reach out to the ICU. This recurrent appropriate ICD shocks is equivalent to again a VT storm. So this is the third spectrum of ventricular arrhythmias that you must realize, that recurrent VT episodes clustering over a short time is a VT storm. It requires a very specialized treatment. All that Dr. Mohan probably told you, beta blockers, amiodarone IV may require ventilation, sedation, ablation, cardiac sympathetic denervation. A whole lot of things need to be done in an appropriate way. So this is a medical emergency. Now, when you see such repeated episodes or a VT episode, one understanding you must have is able to differentiate where it's sustained monomorphic VT, the one that I showed you, versus something called as a polymorphic VT. Now, polymorphic VT has usually a host of other causes. One I showed you is acute coronary syndrome leading to sudden cardiac death. The other host of causes. So acute ischemia is probably the most important, but there are other causes which are inherited arrhythmia disorders. So long QT syndrome, Brugada syndrome, catecholuminergic polymorphic PT. This is a whole gamut of polymorphic PT. This is certainly different than sustained monomorphic PT. Why should you know them differently? Because many of those, except maybe ischemia, you are not supposed to use amiodarone because that can only worsen the situation. For example, take a long QT syndrome with polymorphic VT. You shoot in amiodarone, you cause further QT prolongation, you send the patient into a VT storm. So it's important to make a difference. Whereas for sustained monomorphic VT, it may be the only drug, IV drug available in our country. So that good understanding of whether the many times my ICU doctors don't tell me. They said VT, we shocked. But what was the VT? Oh, didn't look at that, we shocked. No, you have to find out whether it is a sustained monomorphic VT, and that's sometimes not easy from single lead. So if the hemodynamic stability is there, you should record a 12 lead ECG so that you can make that diagnosis, because the treatment differs, because your approach differs, and you have to first learn to make this difference between a sustained monomorphic VT and a polymorphic VT. So what is a sustained monomorphic VT? Usually more than 100 beats. If it lasts for more than 30 seconds, we call it a sustained VT. Now, why do you need to know these rates? Because all our ICDs work on the basis of rate algorithms. Rate algorithm is the primacy of how an ICD works. So cutoff is 100 and above, it is called as a monomorphic VT. Any ventricular rhythm below the rate of 100 is called as accelerated AIVR, accelerated idioventricular rhythm. And then usually the rates of VTs can be anywhere between 140 to 200. So there can be slower VTs or fast VTs, but if they are monomorphic, that is essentially what you need to understand. A little bit on the understanding of VTs, we need to differentiate them as LBBB VTs or RBBB morphology VTs. How do you do that? By looking at lead V1. So for example, this is an LBBB kind of a VT. LBBB VTs could arise from the right ventricle. RBBB kind of VTs could arise more from the left ventricle. Yes, it depends on where the VT circuit exits. If it exits on the left, you get an RBB pattern. If it exits on the right, you get an LBB pattern. So it is, while you can judge where which ventricle is affected, but essentially it reflects the exit site of the VT. So for example, this is an LBBB VT with a left axis. Now, what tells you that this is VT are the following features. Look carefully, there is a slur on the initial part of the QRS. So there is a scar here, that's why there is a conduction slowing, therefore there is a slur in the QRS. There is a deep S in V5, V6. Your forces will never, it's actually a negative concordant pattern. Now, that's what you have learned from your undergraduate days. A negative concordant pattern usually tells you there is a VT. Why does that logic come? Because anything that moves away from the apex will be negative concordant, and no supraventricular rhythm can move away from the apex. Yeah. So this is a very classic reason why this LBBB wide QRS tachycardia is a VT. The slur in the initial part of the QRS, the intrinsic deflection is a little longish. You have a negative concordant pattern, deep S in V5, V6. This LBBB wide QRS tachycardia can be nothing but a VT. On the other hand, you have a narrow QRS. You have a wide QRS tachycardia, which is of a right bundle branch block morphology. Yeah? Now look carefully. If you are to record only this lead in the ICU, or you have to record this lead in the ICU, or you have to record only V5 in the ICU in a rhythm monitor, you would not recognize that there is a wide QRS tachycardia and a VT. This happens many times in our ICUs. People just look at the single lead on the monitor and make diagnosis. This is a particular example to tell you that unless you have a 12 lead ECG, you are likely to miss this as a wide QRS tachycardia, and therefore you are likely to miss that you are going to deal with a VT. How do you know this is a VT? Look at the width. If the width of the RBBB type of wide QRS tachycardia is more than 140 milliseconds, then it suggests a VT. If you look carefully, this is right bundle branch block wide QRS tachycardia with a left axis. So whenever the axis is discordant to the bundle branch block pattern, this is almost a sure shot that this is a VT. obviously you have to look at basic things like, AV dissociation, capture beats. But sometimes it gets difficult when the rhythm is fast. When you look at the wrong lead, for example, if you look at the lead with the highest polarity and at this rate, you will never easily find any dissociation. So yes, when you have a broad QRS tachycardia, you need to have an approach. But before I start teaching you about approach, all of you know very well, hemodynamic instability, first shock, and then we revisit the ECG in sinus rhythm as well as wide QRS tachycardia and try to apply these aspects. But if you have a stable VT, try to make a differential, whether it is VT or SVT with aberrancy. What tells you it's a VT? AV dissociation, that's the sine qua non of a VT. Doesn't happen all the time, 65 to 75% of times, particularly with slow VTs. And if you know to look at the right lead with the narrowest or smallest QRS, then you are likely to pick up AV dissociation. Sometimes even it's there, you miss because you look at the wrong lead. Fast VTs, you can hardly pick up AV dissociation even if it's there. The other aspect are the QRS width, axis, and QRS morphology. And maybe I'm trying to be a little fast on this, but if you look carefully with this, for example, look at this. There is this you must recognize as a P wave. Yeah, you should be astute reader. This is a P wave. So therefore, whenever there is a, see, and all the arrows tell you where the P wave is. So you have to look carefully at the ECG and you'll recognize that I am not trying to bluff, I'm not trying to overread. This is a VA dissociation. If there is a VA dissociation in the presence of a wide QRS tachycardia, obviously it is VT. Yeah, so this AV dissociation is a hallmark. If you see any capture bits or fusion bits through this running trace, maybe here there is something. This might look like some kind of a fusion bit. So if you see that kind of a complex, so when you have a dissociation, you should look at the lead with the narrowest QRS. If you want to look at a fusion or a capture bit, maybe you should look at the lead with the bigger QRS because then the difference will be more apparent. So kind of these are the things that tell you about AV dissociation. Here it's very simple, very slow VT. You can easily pick up a VA dissociation. Now, right lead means what? In this case, lead with the smallest QRS is V1. If you look carefully, your P waves suddenly pop up. They're not difficult to recognize. So the lead with the smallest QRS tells you about AV dissociation. And then in this kind of slow VTs, it becomes a cakewalk to diagnose a VA dissociation. If you look carefully through this wide QRS tachycardia, these are capture beats. Very narrow QRS, as narrow as a sinus beat. These are capture beats. If you see capture beats like that, then you know that there is a VA dissociation and therefore this rhythm is a VT. So AV dissociation, capture beats, fusion beats, sine qua non for a VT. Take this again, right bundle branch block tachycardia. Sometimes the axis may not help you. It's right bundle branch block with the right axis. So when the axis is concordant, it gets difficult to call it a VT. But look at the QRS width. It is almost 180 milliseconds. RBB tachycardia with the QRS width more than 140 milliseconds. Usually it's a VT. Again, the same rule. Remember, I said V5, V6, predominantly negative complexes that cannot happen in a supraventricular rhythm. The forces can never move away from the apex. It has to be a ventricular origin rhythm, which means that it has to be a VT. Here again, same type of rhythm, LBBB type. Now, why this is a VT? The most important thing is this QR pattern. If you look at the QR pattern V4, V5, V6, it not only tells you that it's a VT, there is a scar here also. This is VT in the presence of an old antero wall of MI, which is extending to the anterolateral wall. So if you may not be able to pick up VA dissociation in any of the leads so easily, but LBV type of wide QRS tachycardia, QRS width almost 200 milliseconds, QR pattern in contiguous leads tells you that this has to be a VT. Probably the last part of this is polymorphic VT. Now, polymorphic VT, we discussed briefly. Acute coronary syndrome is the most common cause, which you don't have to miss. Why you don't have to miss? Because you have to treat ischemia actively. Otherwise, your polymorphic VT, you are not getting a handle on it. How do you decide there's a ischemia? You decide ischemia based on ST changes, patient complaints, failure, enzyme, cardiac enzymes. If there is a suggestion of an acute ischemia and a polymorphic VT at hand, this patient might benefit from one choice of lidocaine as a better drug, second from use of anti-ischemic therapy like beta blockers in a good way. If there is a ST elevation, thrombolysis, still better is to go ahead for a PCI. So therefore, the thinking changes when you have a ACS and a polymorphic VT. If that is not the case, you're going to look at the electrolytes. If there is a if there is a dysmetabolism of any form, most commonly potassium levels, magnesium levels, assume potassium and magnesium run together. So hypokalemia, hypomagnesemia, QT prolongation, VT. It's not difficult to recognize. Remember, there is difference between what I call polymorphic VT and a pleomorphic VT. A pleomorphic VT is multiple morphologies of monomorphic VT. Polymorphic VT is change in bit-to-bit morphology in the same lead when you are seeing a wide QRS rhythm. These are usually faster than your monomorphic VT rhythms, about 200 to 250 beats per minute. There is an irregularity. Monomorphic VT usually tend to be regular. The polymorphic VTs usually tend to be irregular, and a particular type when there is a twisting around the axis is called torsade. So for example, here is one such example. Patient has ST depression in the leads, AVR has elevation, ST depression in other leads, something grossly non-STEMI kind of thing going on, gets a PVC, throws a polymorphic VT, out of hospital, this patient is not going to survive. In the ICU, you'll need to shock him immediately. This was particularly during the stress test. Stress tests are usually not hazardous, but if there is a multi-vessel coronary artery disease which is critical, one of your stress tests might show like this. Therefore, it is a standard dictum to have and defibrillator in your stress test labs. Let's move on. Are there more causes of polymorphic VT? There are. Now, this is a complex history of a 65-year-old female who has a myelodysplastic syndrome, diabetic, hypertensive, underlying LV systolic dysfunction coming from the chemotherapy that she's had for C ovary. Because of the immunosuppression, she gets into neutropenia, develops infection, has kidney renal function worsening. Imagine the polypharmacy that is going on here. She's on meropenem, posaconazole, antifungal agent, minocycline. All this is going to cause this kind of an ECG one day. What you see here is that the QRS has widened, the T waves have grown tall, something like a hyperkalemia is happening. Now, this is what you have to recognize on the ECG. Tall T waves, with a wide QRS and almost no sinus kind of a rhythm seen, almost running like an idioventricular rhythm, or somebody might think there is a PR prolongation. Little difficult to say, but this fits into the bill. It is hyperkalemia. These hyperkalemic patients can be throwing in the ICU PVCs like that. And one of those PVCs, while most are on T PVCs, the first two, three are seeming to be okay, but this one was not okay. This are on T. So this is the top of the T wave. You get a PVC, it worsens into a polymorphic VT. This patient will require shocks. In this case, multiple DC cardioversions and had hypokalemia also. So I think polymorphic VT is coming from the QT prolongation. QT prolongation may be related to antiarrhythmic drugs, may be related to number of other antibiotic medications, electrolyte disorders. All that has to be the prescription chart has to be properly read again, needs to be verified what causes QT prolongation. Most important thing is stopping the incriminating drug, not shooting amiodarone, which will worsen the scenario. So I think some of these lessons need to be learned by careful reading of the ECG. Yeah. So polymorphic VT set off by a plate PVC causes of QT prolongation. In this case could be the antifungal agent and hypokalemia, and severe LV dysfunction only adds fire to the whole thing because LV dysfunction, less repolarization reserve, these drugs and these potassiums easily worsen the scenario. Okay. This is the ultimate truth. Ventricular fibrillation. You don't record such 12 lead ECGs in ventricular fibrillation. I don't know how this one got recorded, but any single lead can tell you. Now, in Zest, you always say that look carefully at the patient when you see such an irregular rhythm, because one day your ICU might be throwing up an artifact because of lead movement, because of the lead damage happens many a times, or if you have some in OT in operating room, some electromagnetic interference coming from multiple devices around you, then a single lead might show you this rhythm and the patient is all well. Don't shock him. This might be artifact. Just give a thought to it. But if the patient is collapsing and you have this rhythm, obviously it is ventricular fibrillation and nothing can save him more than a shock. You need to, in appropriate situations, preempt that and have you have your defibrillators in the ORs, in the stress test rooms, probably wherever cardiology is going on. At least when you're on the floor, you should have one defibrillator that can be quickly brought in, and your code blue team should have will obviously have this. They should be in every hospital made, because otherwise these VF patients are not going to survive. Here is another situation where you have polymorphic VT, only shock can salvage these patients. So this is the whole gamut of ventricular arrhythmias that you see. I didn't want to be too incisive in each of these packs, but you must realize there is every ventricular arrhythmia is not bad. So you must learn to define idiopathic PVCs, quantify the burden, see the etiology. Second step is you have a sudden cardiac arrest, which is one end of the story, where bystander resuscitation has to come up in a big way in our country. Return of spontaneous circulation, look for acute coronary syndrome. If that be the case, it takes. If you have VT, try to classify monomorphic VT, polymorphic VT. Polymorphic VT, acute ischemia can be the cause, electrolyte disturbances can be cause, multi-drug therapy can be the cause. If it is monomorphic VT, think of a scar. Scar usually post-infarct LV dysfunction is the most common subsets in our practice. The other is non-ischemic cardiomyopathy, for example, sarcoidosis. There are other etiologies like hypertrophic cardiomyopathy, arrhythmogenic right ventricular cardiomyopathy. So these are, and both monomorphic VT and a polymorphic VT can equally go into a VT storm. VT storm is an emergency. If the patient has ICD, it needs to be programmed. You find out what the reversible causes are. Every time there's a VT storm with a monomorphic VT, does not mean the coronary angiography is going to save the day for you. Optimize the medical therapy with escalation of beta blockers and amiodarone. That doesn't work. Pro, every time you step it up further, deep sedation, intubation doesn't work. Ablation, cardiac sympathetic denervation by a thoracoscopic method, and LVAD at a certain late stage if he's a heart transplant candidate as a bridge to heart transplant. So it has to be that aggressive depending on what the patient deserves and where in the center you are. But these patients sometimes need to be transferred to tertiary centers for effective treatment. I think I'll stop here. It had to be a little going through the whole whole gamut of ventricular arrhythmia a little fast to give you an idea of what we are discussing. Thank you very much. And we can take some questions, and then I would like you to take you through some quiz where we can have Dr. Mohan and Dr. Kumla participating. Dr. Kumla, you want to add anything?
It was no, nothing great. It was really a great lecture on ventricular arrhythmias, especially ventricular tachycardia. Dr. Ashish Nabar went through it very well. It is a common practice which he said in ICUs, very difficult. Single lead they see, and then they start the gamut of treatment. Many times they are successful, or many times they are unsuccessful. And hypokalemia, which is again hyper and hypokalemia, is many times missed, and you have all sorts of arrhythmias. And about PVC burden, he really spoke about that. What is the quantity of PVC to be said that it is really higher and can give rise to PVC-induced cardiomyopathies. Ashish, can you tell me what percentage of PVCs you should take? Many times you have on a Holter monitor where we have say thousands of or the percentage may be 10%, 15%, sometimes they write 30%. So which percentage we should ignore or which percentage you should treat?
So basically, it has to be understood that we are talking of, say, structurally normal hearts, a monomorphic PVC repeating itself. You are going to carefully read that PVC if it is from the outflow tract, and then you are going to see what the PVC is doing. Is it causing symptoms? Is it causing subtle symptoms which may be missed? You are going to do an echo to see if there is LV function affected, sometimes subtly, and that together with the PVC burden would make more sense. So usually a burden about 20% is considered as a significant burden. 10 to 20 is considered as a moderate. Now, these are not something golden truths. They have entered the literature in some studies, but if you have a 20% burden, but if there is good LV function, there is no symptoms, even subtle symptoms when you interrogate, and because they vary from time to time when you monitor. So if you just don't go by the number of the PVCs, but just try to understand whether that PVCs are causing some symptoms. Sometimes they can be subtle, whether they are causing any LV dysfunction, that can also be subtle. And when they are causing or there is onset of harm in this way, then you can react, and react in the sense of if they are outflow tract PVCs, then most electrophysiologists would tell you that they can get it most of the times by ablation, and then it is definitely a way to go ahead. But it is never a bad idea to use suppressive therapy like beta blockers to see if the load reduces and makes them asymptomatic, or if the load reduces and the LV function improves. In that case, it is also possible to go a little steadily on them and not make ablation necessarily as a first choice the moment you see 25% on the Holter.
Thank you.
Dr. Mohan, you wanted to add anything, please?
No, thank you. I think excellent talk by Dr. Nawar as usual. And I think it is very practical, very clinical, and it is useful to every clinician who has listened to.
Thank you, sir. So there is a little quiz that I wanted to do. I think I'll stop share and then reshare maybe for the quiz, I guess. So I do the share again, and there is this one. Can you see that?
Yes, sir. You can go to full screen. Yeah.
Yeah. Can you see that?
Yeah, we can
Okay.
see, sir.
So some ECGs that we can discuss because they always break the monotony of the talks, and like they say, a picture is more than 1,000 words. So I think that would be the value of doing some ECGs. So here is a 35-year-old man who is evaluated for palpitations and one remote syncope, which he hardly remembers, or say 2 years ago, he says. And he comes to you with the ECG. Obviously, many a times they don't come with the event ECG, meaning the ECG when he had a syncope or when he had palpitations, because they are short palpitations, and you record a office ECG, and the ECG looks like this. And the question to you, to the audience, would be which echocardiographic finding is more likely? So would you call it an inferior wall infarct? Would you call it RV dilatation with severe PH? Would you think this patient would have RV dilatation with normotensive TR, or would this patient have dilated LV cardiomyopathy?
Bhaskar, please start blank uh, polling.
No, I
So we
think
will.
Yes,
I
please.
wonder whether
Yeah.
you don't have the option, so I don't know whether. Oh, you can. Can you
No, it
poll?
will work. It
Okay.
works, sir. Yeah.
Okay, so it is in this ABCD form. If you can do something
Yeah.
about
Yeah.
it.
Yeah. Yeah. Already polling is live, and we can vote. All the
Okay.
audience, I request, we just wait for next 10 seconds.
Okay, can we see something?
Yeah. So I can just say, sir, option
Yeah,
1,
yeah.
33%, B 33%, C 17%, D 17%. So
Right.
it's
So this should ideally not be a difficult ECG. Dr. Mohan, would you like to expand on this?
No, no, so obviously the inferior wall, regional valve abnormality is unlikely. It is not. There is nothing actually in AVF or L2. The RV dilatation with severe PH. I don't see right ventricle hypertrophy strain. I don't see right axis deviation. I don't see clockwise rotation. I will not put severe PH. RV dilatation, normotensive TR, very much likely in my view, because that kind of V1, V2, V3 actually with the fragmented QRS with SD segment, which is more like a right bundle branch block thing with fragmented QRS. I would think in terms of ARVC actually,
I
and
think
dilated
so.
LV, dilated
Yes, sir.
LV cardiomyopathy. I don't see any evidence for the left ventricle to be involved in this issue.
Right. So LV voltages are not tall, the QRS is not broad. So obviously Dr. Mohan rules out dilated LV cardiomyopathy. And this is a typical right bundle branch plot, and which is typically said as an epsilon wave. And this is a sine qua non for arrhythmogenic right ventricular cardiomyopathy, which on the echo would present as RV dilatation and maybe some TR and some RV free wall changes. At least in this presentation, we are not elaborating beyond that. Okay. So this patient has HCM, which ECG findings suggest the presence of a septal hypertrophy. Yeah, let's go through this. Tall R in V4, V5, V6. Does it mean septal hypertrophy? Deep Q in V5, V6. Sorry, I am covering my options. Okay. Deep Q in 1 AV, 1 V5, V6. Tall T waves in V2, V3. And let me see.
Yeah. Bhaskar, please push the blank.
No, 1 second. No.
The
I'm having some difficulty in getting my thing out. But could you see that? What is the last option? Yeah,
Uh,
okay. Narrow QRS. Okay. So which one indicates that there is a septal hypertrophy? This is mainly, you understand that hypertrophic cardiomyopathy is associated with asymmetric septal hypertrophy, or that is probably the well, most common variant of HCM. And the septum, as you know, is activated from left to right. The left bundle, left posterior fascicle activation is the first to happen, and then the septum is activated from left to right. If you have a hypertrophy of the septum, then your V5, V6, which are usually very small in when the septum is not hypertrophied, very well insignificant, so to say, reflecting the initial part of septal activation from left to right. Therefore, your small Q is in V5, V6. The septum is hypertrophied, these Q waves will get amplified in V5, V6 and 1, and therefore what reflects, so yes, it is true that tall R V4, V5, V6 is LVH, but my specific question was what tells you that there is a septal hypertrophy, and this Q waves in V5, V6 tells you about septal hypertrophy. Many times you're likely to mistake them for infarct pattern, and that's where you have to stand guard. LV hypertrophy of that nature, and not so broad QRS, and the V2 itself prominent may also tell you about septal hypertrophy. So it is this that you have to be on guard. There are these mimics. Sometimes pre-excitation is considered as in old infarct pattern. Sometimes this kind of a septal hypertrophy is misunderstood as an infarct pattern. What is the location of the LV scar? It is confirmed that there is a scar on the MRI. There is no scar. There is anterior wall scar. There is a posterolateral scar. There is a apical aneurysm. This is the ECG. What tells you that there is a LV scar on the ECG? So your ECG reading has to be good because you have a patient with a VT and you have a sinus rhythm ECG. And one of my colleague told me that the ECG was normal, and this was indeed not.
we got maximum voting for option A, 57%.
Well, I said that there is a scar. It is confirmed on the MRI. Yeah, anybody would want to take Dr. Mohan or Dr. Kumla?
So it has to be apical one. The reason is this is a right bundle branch block pattern, has to come from left ventricle. It is a superior axis, so it has to come more from the apex. My guess will be it is an apical aneurysm.
Yes, so when I saw this, I called it as a posterolateral for the reason that there is a tall R in V1, V2, V3. As you know, that an old infarct
Yeah.
pattern for the audience is suggestive of posterior wall infarct. And when you have loss of R waves, now loss of R waves as a synchronon of a scar is less understood and less popularly understood, and probably not paid attention to. So you, of course, Q waves is equal to a scar, that everybody understands, but loss of R waves when it should have been there, and unnecessary tall R waves when they are not supposed to be there. So V1, V2 need not have that kind of a R wave, and V5, V6, as most of you would know, V5 should have the tallest R wave because it is exactly at the apex, or V4 should have the tallest R wave. So after a tall R wave in V4, V5, in the V6 would be a little lesser, but not less to this extent. I mean, when you have V3, V4 of this magnitude, you don't have V5, V6 of that lower magnitude, and that's how. So I also take Dr. Mohan's point, and the MRI, I don't have it here, but that could confirm for us as to where the scar is. I think both of the options can be debated a bit. Which abnormality is not suggested in the ECG of this patient with severe LV systolic dysfunction? So this patient has LV systolic dysfunction. Now that is very difficult because in a patient who does not have dyspnea, who records it for executive health checkup, there is probably not a reason that you will easily say that. But yes, there is a queue in V1 to V4. Most important, what I wanted to get home to you is the low voltages. So another way the scar can present is with low voltages. Sometimes these low voltages can be when people are in pulmonary edema, that becomes an insulation. The ECGs are recorded from the surface. You have pulmonary edema, low voltages are recorded. When these people are diuresed well, then the voltages pick up. So that's another something that one might keep in mind. But what abnormality is not suggested in the ECG of this patient with airway circulation? Is there an interval scar? Yes. Sinus node dysfunction? No. What are we talking? The heart rate is some 60? No. Low voltage QRS? Yes. Repolarization abnormality? Yes. There is some kind of a V5, V6. So what is not is a sinus node dysfunction. And sinus node dysfunction is not something that is equivalent to a LV systolic dysfunction. Okay. Now let's take this. So this was all about scar and picking up scars. So which ECG sign is a proven SCD risk predictor? See, ECGs can tell you there is a scar, but scar is not equivalent to saying the SCD risk. So therefore, if you have this patient with heart failure, what will tell you that this patient is at a high risk for SCD, and therefore you might even jump the gun and say, I would recommend a primary prevention ICD to this patient. A proven sign. You want to take a poll? One second, I'll show you the options. LBB
Yeah.
pattern, sinus tachycardia, QT prolongation, fractionated QRS. So now all these are possible in a heart failure patient. LBBB pattern with a heart failure patient, LV systolic dysfunction. You are extremely happy to see such a ECG because CRT may mean something this patient. Sinus tachycardia in a heart failure patient important because this patient might be decompensated. Just check out whether there is an overt heart failure. QT prolongation is again bad news, but in the presence of an LBBB, your QRS width will have to be subtracted from the QT to make a judgment on whether the QT is really prolonged. And this doesn't happen often, and people stop amiodarone prematurely saying that the QT is prolonged when this broad QRS is a wide QRS is actually contributing to that. And fractionated QRS, if you can judge or if you can look at the leads, sorry, if you can look at the leads 2, 3, AVF, V5, V6, even V4, this fractionation that you see in the QRS. So I will make this discussion short. All of them are fitting with an LV systolic dysfunction. But what is proven is fractionated QRS tells you that there is a scar in the heart, and therefore these people are more at risk of sudden cardiac death, and they should probably get even a primary prevention ICD, and that would seem like justified. So that's what I wanted to get here. Okay, let's go to ventricular arrhythmias round. Now, probably all three of us are cardiologists. Dr. Mohan is the most experienced. We see less and less of medicine these days. But here is a 20-year-old girl. Tuberculosis rampant in our country. Multi-drug resistant also common. They often require bedaquiline. What is this? These patients with bedaquiline often get it in hospital scenario. Their ECG is very okay. As a cardiologist, you are sometimes asked to interpret these ECGs, and I don't like this ECG when this patient is given bedaquiline. Why do I don't like it? Because she's going to get a monomorphic VT, because she's going to get a pleomorphic VT, because she's going to get a polymorphic VT, or because she's going to get atrial fibrillation. Dr. Kumla is here. Yeah.
Polymorphic VT may be a common thing which we may see.
Yes. So what are the features here that makes you think that, sir?
Okay. Deep T wave inversions are seen from V1 to V3.
Yes. It is hitting you in a big way. This QT is absolutely prolonged more than half of. So even if you're not on a quick clinical rounds calculating the QTC, but this QT is obviously more than half of RR. What is more important, see the QT alternance. QT alternance is equivalent to a repolarization disorder. So therefore, if you see such a long QT alternance, you have to do something about the beta-qualin. Here, in fact, if you look at V5, the QT polarity itself changes. So this is bad repolarization disturbance. Beta-qualin is known to cause, and this patient is at a risk of polymorphic VT. This patient will certainly require reduction in the doses of beta-qualin.
In fact, it is nowadays used, I think, secondary
Yes,
tuberculosis.
it is, yeah,
Second
for
line, second
multi-drug
line.
resistant. Yes. Wide QRS tachycardia, which amongst the criteria enumerated here does not necessarily favor a VT? Capture beats. Can you see them? Yes.
No.
There is in the last lead, if you see, these are capture beats. Narrow QRS, narrow QRS, narrow QRS. Favors a VT? Yes, favors a VT, basic thing. RBB wide QRS tachycardia with more than 160 milliseconds. So if some of you listen to the talk that I gave, RBB tachycardia, wide QRS tachycardia width more than 140 VT. LBV tachycardia, the criteria stiffer more than 160, then think of a VT. Now, all these criteria have a 65%, 70% sensitivity. So you have to apply multiple criteria to get under the diagnosis. But in this case, QRS width is more than 160 millisecond would favor a VT. Concordant axis. So what does this wide QRS tachycardia? Right bundle branch block pattern, right axis. This is something that is not in favor of a VT. Does not rule out a VT, but if you have a right bundle branch block, left axis, definitely VT. But right bundle branch block, right axis, you cannot make a diagnosis of VT or SVT based on that. It can very well be a VT. It doesn't rule out a VT. Yeah. Discordant axis tells you that it is a VT, but a concordant axis, you'll have to apply more criteria to say whether it's a VT. And monophasic right bundle branch block pattern. So amongst the criteria that you know, dissociation here with the capture bit makes the whole game very easy. But there are other things that tells you that it's a VT. What misleads you is a right bundle branch block right axis. But what already cleans the diagnosis for you was a capture bit, monophasic R. So monophasic R, biphasic R are all for VT. Triphasic can be a SVT. And look at the deep S waves in V5, V6. That is something that is glaring. If you have this kind of deep S waves in V5, V6, forces moving away from the apex is what it essentially means, then this is likely to be a VT. So these are some of the things that you should kind of know, and they tell you that is a VT. In addition to the fact that there is a QR pattern in 3 and AVF. So this may be that there is a scar in the inferior wall. So this VT is in the setting of an old inferior wall MI. So these are the number of things that one should be able to read. Again, a wide QRS tachycardia that was recorded. Monomorphic VT is usually usually regular. Polymorphic VT is usually irregular. And there are certain monomorphic VTs that happen in the setting of an infection. So if you have myocarditis, your monomorphic VT can be irregular. That is the reason to bring this. What is the definitive treatment here? RF ablation, in ICD implantation, pacemaker implantation, oral amiodarone. I remember what my teacher used to say, Professor Wellens, fast, broad, irregular tachycardia, FBI. FBI is, look at the onset of the QRS. Look at the onset of the QRS here. It is slurred. It is slurred. It is slurred. A slurred onset can mean two things. One, the ventricular activation is happening muscle to muscle. This can happen in two ways. One is in a VT. The other is when you have a pre-excitation. When you have an accessory pathway which inserts into the myocardium, the activation of the ventricular myocardium is cell to cell. And both these scenarios, you can have a slurred onset. But monomorphic VTs are usually regular. If you have a irregular VT like this is a fast, broad, irregular with a slurred onset like that. It is likely to be a atrial fibrillation that is pre-excited by traveling down the accessory pathway. So therefore, what is the treatment for that scenario? Obviously not putting ICDs. Obviously, no pacemaker obviously has completely no role. And oral amiodarone, when will it terminate such a tachycardia? Definitive treatment is what I'm asking you. Definitive means for this patient to not have a recurrence, you will need to ablate the accessory pathway. Most of these patients, after the ablation of the accessory pathway, at least the younger patients, don't have AFib later. What is not the ECG diagnosis in this patient? What is not the ECG diagnosis in this patient? Is this patient having a complete heart block? PVC is short coupled, PVC RV origin, right bundle branch block.
H.
Yes. So you are right, Dr.
Complete
Kumla.
heart block.
There is
AV
obvi there is
complete heart
there,
block.
there is obviously a hard block here. This P wave is conducted a PVC, but this PVC and this P wave is too far. It cannot be, this PVC cannot be conducting retrogradely into the conduction system, and therefore this is blocked. This is very unlikely because this VA is too long. If this P wave was coming here, then that is one consideration. Is the PVC short coupled? Yes, short coupled you say when the PVC is falling on the downslope of the T wave. Why is this important? If the PVC falls on the upslope or on the first part of the T wave, it is highly refractory time for the ventricle. Such PVC will never lead to a tachycardia or a ventricular fibrillation. But if the PVC falls on the downslope of the T wave, that is when the ventricle is vulnerable to again getting excited, and this PVC can lead to early or late after depolarizations and cause a ventricular tachycardia. That is possible. Right bundle branch block pattern, again very clear, the conducted P wave is with the right bundle branch block pattern. So obviously PVC of RV origin is not correct, because if the PVC is of a, where is that? Yeah, if the PVC is here predominantly RBPB type, so it is not from the RV origin. RV origin PVC will be usually a left bundle branch block type. Sorry. Okay. So the many times Dr. Kumla discussed initially about the Holter recordings and wanted to say some things. Here is one such question. These are high risk PVCs. Now these are high risk PVCs because they are of LV origin, because they are short coupled, because they are repetitive, because they are monomorphic. What means that the PVC? So when you read the Holters, there are a number of things that you see. Of course, Holter, it is very difficult to say LV or RV origin. That's only possible in a 12 lead ECG. Short coupled, long coupled is of course something that you have to see, because we just now discussed that the short coupled PVCs falling on the downslope of the T waves are likely to cause a polymorphic VT. Repetitiveness, this was what was when the PVCs were studied in the initial days, it was thought that the burden of PVC reflects the risk of sudden cardiac death, which we eventually came to understand that it is not only about burden, it is more about the underlying structural heart disease, if any. So PVCs by themselves, the burden doesn't reflect the risk of sudden cardiac death. So repetitiveness not. Monomorphic PVCs probably is nothing to say that it's high risk. What feature in this ECG tells you that there is a high risk is that these fall on they are short coupled. So LV origin doesn't mean there is high risk. Repetitiveness not necessarily. Monomorphic not necessarily. What is the strongest reason to believe that these are high risk PVCs is because they are so closely coupled and that they are falling on the downslope of the T wave. Here is one such almost kind of happening. You have a couplet here. If you look at the rhythm strip, this PVCs are marching through, but this one gave rise to another PVC. So if you have these monomorphic PVCs and the second PVC beat in that couplet is of a morphology that is a little different or much different than the recurring PVC, that should be considered as a high risk, because it means that the wavelet is breaking. If the wavelet monomorphic PVC is a re-entry, if that re-entry is breaking and causing a PVC in the second beat, it is likely that this breaking will continue and cause a polymorphic VT. So a second PVC of a couplet of a different morphology has to be taken more seriously. So close coupled and a second beat which may be of a different morphology would increase the risk. Okay, now this is a Google.
One question.
Yeah.
PVC is disappearing with treadmill. What do you think of that?
Yes, that is something that we did not discuss. It is for the PVCs, we talked a lot about Holter and burden. The other thing is to evaluate whether those PVCs make a full-fledged monomorphic VT. For example, if you have outflow tract PVCs they are often increasing with the exercise and make a monomorphic VT. And then if you have a history of syncope, this idiopathic monomorphic VT patient, I'll definitely bring to the lab because it's likely that we can ablate them successfully. But if the PVCs get suppressed, which is very common, many of these patients with after executive health checkups come for evaluation of those PVCs. And one thing, of course, you do when you subject them is to see if there's a coronary artery disease. That's okay. But if there is a suppression of PVCs with exercise, that tells you that convinces about the benign nature of the PVCs, especially when there is no background structure heart disease. So this is something that we did discuss, right? Thanks, sir. Here is one question. Now, we talked all the time about wide QRS tachycardia and trying to diagnose VT. You have a narrow QRS tachycardia here. Narrow QRS tachycardia here. What is the medication what would you do for acute termination of this tachycardia if he presents to the ICU? Would you shoot IV verapamil? And then obviously you know why you're doing that is because it's right bundle branch block left axis. You say it's fascicular VT because it's a discordant axis, right? Right bundle branch block left axis. The axis is discordant to the QRS, which means that you're trying to diagnose a VT overlooking the fact that it is narrow QRS. And then when right bundle left axis, you have learnt in the ECG courses to talk about a fascicular VT, and the answer for fascicular VT is IV verapamil. Would you want to do that here? Second. IV adenosine, obviously, the moment it is narrow QRS tachycardia, if you don't understand anything, IV adenosine blocks the AV node, terminates a SVT, shows more P waves than the QRS when it is atrial tachyarrhythmia. So, IV adenosine, either therapeutic or diagnostic. Is that what is playing on your mind? Third thing is IV amiodarone because you know it's the golden drug. Do anything, amiodarone is forgiving. This tachycardia will terminate. Let the electrophysiologist find out what the rhythm was. But let me play safe, give IV amiodarone. Or I have heard somewhere that a bolus dose of flecainide can also terminate atrial fibrillation. There is slight irregularity here. I think this is a AFib, and I give a oral flecainide bolus dose, pill in pocket approach as they call it. What would you do here? Let's take a voting just to have some fun. Can you do that?
Yeah, we can do that. Yes.
Okay. So there are many googlies here. It's a right bundle branch block left axis. It is a narrow QRS. And what more can you read on the ECG?
So we are getting like 43% for option B.
For B.
And then C, 38%.
Right.
Yeah.
So I don't know why people chose C. They have a good answer, but probably I suspect that they don't have a good argument. Now here it is. It's a narrow QRS tachycardia. So you are bound to think in terms of SVT. Why you may not think is for the following reasons. 1, 2, 3, 4. 1, it is right bundle branch block with left axis. So discordant axis usually tells you that it's a VT. If you look carefully at this beat, this is of a different morphology than the other beats. So therefore, I guess you're seeing my arrow, right, or not?
Yes, we can see it.
Yeah. So this is the beat which is with a narrow QRS. So this has to be something like a capture or fusion beat. Number 2. Number 3, you have V5, V6 extremely negative. And I said it 100 times during this presentation that something that is extremely negative in V5, V6 is moving away from the apex or is originating in the apex. And there can be no accessory pathway or no SVT despite whatever aberrancy that can start a ventricular activation at the apex. So this kind of a negativity in V5, V6 is for a VT. And also I repeated a couple of times that you have a QR pattern in the consecutive leads. The QR pattern tells you that here is the scar. The QR pattern in V1 to V3 to V4 almost tells you that the scar is in the anterior wall. And therefore, this is a VT1 because you have a capture fusion beat. Secondly, you have a discordant axis. Third, you have deep QRS in V5, V6. Fourth, you have a QR pattern. So there are these many things that tells you that despite being a narrow QRS tachycardia, you have to look the other way. And the other way means not using the drugs that you use for SVT, adenosine will probably not do anything. Verapamil will crash the patient. Flecainide will kill the patient. Amiodarone will save the patient. It is likely that the amiodarone will terminate this VT. If not, if there is hemodynamic instability, obviously shock. So these are some of the ECs. I think maybe one more. Yeah, this is what I think Dr. Kumla was trying to say. This is a Holter excerpt from a 20-year-old boy complaining of episodic palpitations. So you didn't have PVCs, but you are lucky to record a sustained monomorphic VT, wide QRS tachycardia. This is a sinus beat here. If you look carefully, probably nothing wrong. 20-year-old boy should not have anything wrong. Maybe some form of a cardiomyopathy plus minus, but this ECG does not even suggest that. And you have a monomorphic VT. What is the morphology of this monomorphic VT? Look at carefully. Should he get an ICD? Why? Young guys may need an ICD if they have a cardiomyopathy leading to a monomorphic VT. Is it an outflow tract VT? So ablation is the other option. Is it RF ablation in the proximity of left posterior fascicle? Meaning, is that an idiopathic LV tachycardia? So, will you, if you have to ablate, where will you ablate is the question, in the outflow tract or in the left posterior fascicle? So, are you talking of an outflow tract VT or are you talking of an idiopathic LV tachycardia or a fascicular VT? And the last thing is, I don't understand anything. Amiodarone and beta blocker always works for me. What would be your best definitive treatment? Now, antiarrhythmic drugs were never definitive treatment. So, by that logic, you can take this out. If you carefully look at the QRS, what you must see that there are tall QRSs in 2, 3, and AVF. If there are tall QRS in 2, 3 AVF, that means the ventricles are activating in a craniocaudal direction. And what is cranial in the heart? These are the outflow tracts. So therefore, we forget for a while trying to say LV or RV outflow tract. This source of this wide QRS tachycardia is in the outflow tract, not in the left posterior fascicle, which usually gives right bundle left axis. Outflow tract usually gives tall R in 2, 3 AVF, and they're obviously wider, whereas fascicular VTs are usually a little narrower. So therefore, when they're outflow tract VTs or fascicular VTs, we don't put ICDs because there is hardly a risk of sudden cardiac death. Ablation works wonders in these patients to treat them curatively. I think that's what I had to present, and we can hope that that might have been useful to the attendees.
Sir, there are some questions in the chat of Zoom. If you can just speak and select for the discussion.
I don't know. 1 second.
Okay, I can quickly take question number 1.
Yeah, that would be better, sir.
Which beta blocker drug of choice in ischemic heart disease with bradycardia? I think you would have to define the severity of bradycardia, and somebody who already has bradycardia, why do you want to give him beta blocker? My point is, unless of course you want to take patient is in heart failure, you want to take the benefit of beta blocker, you want to give a pacemaker first and then give it. It is a tricky question actually.
So the only two things I would say is, one is, as you rightly said, Professor Mohan, that if there is a tachybrady, then you might give a pacemaker and then drugs. That's what sir explained. The other thing is, many times people wrongly have PVCs and call it a bradycardia because that's how the machine records, or and then obviously it is not treating bradycardia but treating the PVCs. I can only say that, but you're right that it's a funny question.
After prolonged use, the population of beta 2 receptors increase. Still, the beta 1 receptor blockers will carry out their desired function. After prolonged use, the population of beta 2 receptors increase. No, beta 2 receptors are actually intact even in heart failure. It is the beta 1 which get desensitized and their number decreases. And you, by giving beta blockers, you are increasing their number, and of course, that is how you have. Beta 2 receptors are largely in atria, and these are unaffected in heart failure. They don't increase in ventricle. Ventricle, they have very little beta 2 receptors. Can ECG pattern guide choice of antiarrhythmic therapy or beta blocker? I think, Ashish, you can take it.
See, basically, we are talking over the same thing is that if there is a ECG pattern doesn't guide, it is treating tachycardia or heart failure that guides the use of beta blocker. Of course, we're not talking hypertension here. That is another reason why you may use, but talking of tachycardia or tachycardias or heart failure is where we use beta blockers, and I think this was extensively explained in the talk. So, whichever tachycardia, it is atrial fibrillation, the beta blockers are for rate control. For ventricular arrhythmias, it is more for suppressing the sympathetic tone and thereby preventing the trigger of getting into the ventricular arrhythmias. For heart failure, it is the same mechanism. For long time, we misunderstood beta blockers were bad for heart failure thing until very convincing trials came out and said that beta blockers were good for heart failure because heart failure has a higher sympathetic tone. If some of you know about the the RR variability is reduced, which means the sympathetic tone is very high, and that's where beta blockers help to curb down the sympathetic tone in heart failure. So these are the understandings behind using beta blockers. And then obviously, if your ECG helps you to find out the etiology of the tachycardia or all the underlying structural heart disease in a heart failure patient, then that's where your question might be hinting at.
Yeah. Obviously, if
And
the
the thing that
QT is prolonged, then of course you have to look at it different way. You obviously cannot be using amiodarone or sotalol in these individuals.
And the thing is that
Yes.
we have to stop beta blocker suddenly because the beta 2 receptors have been liberated. Uh, that is one of the reasons maybe our sudden surge of blood pressure or patient developing acute coronary syndrome with withdrawal of beta blocker.
Yeah, that actually it is more of a risk which is talked about. Is not that common because a lot of our patients stop quite often. They stop it abruptly and nothing happens to them. But
Okay, okay.
theoretically, you are right. I would agree with that logic. And dose titration, I think is simple. We still go the three steps: 2.5, 5, and 10. You can use 2 weekly actually a regimen, or maybe even shorter than that if the patient is all tolerating. Since bisoprolol has a dose response curve which is linear, it's a good idea to start with the 2.5, 5, and 10. Of course, in heart failure, a lot of people start with 1.25. But you are talking of ventricular arrhythmia. You might actually start with a bigger dose, but then the risk of significant bradycardia is always there, and AV blocks is always there. So a good idea to start with the 2.5 milligram.
Dr. Kumla and Dr. Mohan, if you can excuse me, I have a flight to catch from Lucknow. I'll thank you very much
All,
for
all
the
right,
question.
Ashish.
Thank you. Thanks a lot,
Right.
both of
I think even I am busy over here, so we might conclude the meet.
Yeah,
Yes,
sure.
sir. Yes, sir.
Yeah,
Sure.
it's already 2 o'clock now. Thanks everyone for having attended this meet. It was a wonderful discussion between Dr. J.C. Mohan and Ashish Nabar. I really enjoyed Dr. J.C. Mohan's talk, as Ashish Nabar said. Wonderful elaboration of beta blockers in various settings. And as usual, Ashish Nabar discussed very well on this topic about PVCs and ventricular tachycardia. Thank you, everyone.
Thank you, sir. And on Merck's side, I just wish to inform that this was amazing because we had almost 1200 plus live logins during these 2 hours of master class. So thank you so much to Professor Dr. Mohan sir, Dr. Nabar sir, and Dr. Kumla sir for your time on Sunday and also giving such an insightful talk and interactions. So thank you, sir. Good day to
All right.
everybody.
Good.
Bye.
Thank you.
Bye.
Thank you, doctors. Thank you, everybody, for joining. Have a great day. Bye-bye.
ओम ब्रॉडकास्ट बंद कर दो थैंक यू